love to introduce you to Dr. Amanda Firth of the University of Huddersfield in the UK. She's a midwife and academic. Her research focuses on improving understanding, recognition, and support for women and families experiencing mental health difficulties during the perinatal period. Amanda's work seeks to tackle health inequalities affecting minoritized women during the perinatal period, with a focus on improving equity, access to care, and developing culturally responsive maternity services. Amanda is committed to advancing perinatal mental health awareness within maternity services and education, engaging in research that aims to improve outcomes for all mothers, babies, and families. Let's all welcome Dr. Firth. Thank you so much, Amanda.
Thank you, and that was a lovely introduction. I forgot that I'd written that quite a while ago. There we go. So yes, I'm here in Nottingham, cold. You might have heard earlier on, I've actually got central heating on in the cardigan, so we're definitely still in that springtime weather. And what I would like to speak to you today is around the thing that actually made me a doctor, the doctoral research that I did, which was a wider project looking at how we can develop more effective maternity services for asylum-seeking and refugee women with perinatal mental health concerns, because we know that there are issues around that, and the efficacy of the services and the equity of the services that we provide in the United Kingdom. But there was a really strange subsection of the data that was all around things that midwives were doing to try and help refugee and asylum-seeking women's mental health that were actually invisible to women, that had a huge impact on whether they received care or not, or the care that they were able to receive. So what we've done, or what I've done, is take out that section of data and look at it particularly from a salutogenic perspective. So what I'm going to talk to you today about is how we can strengthen midwives' well-being when we support forced migrant women, asylum-seeking and refugee women, with regards to perinatal mental health screening, but particularly from a salutogenic perspective. Can I have the next slide, please? So just to set the scene, and set the scene from a UK perspective, but actually this mirrors what's going on in the rest of the world as well. We know that asylum-seeking and refugee women have increased challenges with their perinatal mental health for very obvious reasons. Women who are seeking sanctuary in the UK by the very virtue of the fact that they've forcibly left their own country are more likely to have experienced trauma. They're more likely to have had difficult journeys, difficult migration interviews when they arrive. They're navigating unfamiliar healthcare services, and may have left, or most likely have left, family in their home country, and are trying to establish a life and identity in a new country, as well as pregnancy and navigating maternity services as well. On top of all that, we know that there are increased barriers in accessing adequate perinatal mental health support within the United Kingdom. And again, that mirrors what we know globally as well. It's fair to say that a lot of the literature around asylum-seeking and refugee women's perinatal mental health kind of is most strongest represented in Australia and Canada, with a small amount in England and the United Kingdom as well, and pockets across the rest of the world. And the Canadian and the Australian literature does mirror what is going on in the UK, but I think what we're presenting here, from what I can see within literature, is the very first time that we're going to look at this through a salutogenic perspective around midwives' wellbeing. And that's because there's lots out there in literature around how women navigate barriers to accessing services, or how they struggle to do that, and how they struggle to have their needs met. But what we know less about is how midwives manage that, and the impact that has on their health and well-being as well. So the aim of this section of the study was to explore how midwives experience and manage the emotional labour and systemic demands of supporting forced migrant women's perinatal mental health needs. Can I have the next slide, please? So with this, the underlying kind of philosophical principles around this are the theory of salutogenesis, and I'm going to take just a couple of minutes to explain that. Some of you might be very familiar with it. For some of you, it might be newer. So basically, this theory comes from a gentleman called Aaron Antonovsky, who actually, this theory came out of research around some of it's from Holocaust survivors actually, and him trying to kind of figure out why some people had really quite poor physical health but had a better perception of they perceived that their health and well-being was better than some people who had better physical health but felt more unwell in themselves. And what he says basically is that health is on an ever-moving continuum. It's not static. It doesn't, you're not just healthy and stay healthy or ill and stay ill, but actually that moves along that continuum day to day. And that it really focuses around your sense of coherence, affects how healthy that you feel. And that sense of coherence is underpinned by 3 principles that we're going to talk about in a minute. But basically, he says that actually, if you've got access to things called general resistance resources, aspects or resources that strengthen your ability to navigate the world and your environment, then you're more likely to feel healthy. And those are salutogenic, they're health generating. But if you have less of those resources or a deficit of those resources, you're more likely to feel unwell or pathogenesis. So the absolute opposite of health. And some of those are internal, some of them are external. So some of them is internal, like emotional intelligence and things like that, but some of them are actually being able to access material resources that would help you to navigate the world, such as social support. It might be access to food banks and things like that. But we're going to look at this from the perspective of midwives, and that will become clearer as we go through the presentation. Can I have the next slide, please, Ali? So Antonovsky said that there are 3 key elements to sense of coherence, and we're going to look at these within the data today. So he said that when someone has a good sense of coherence, they're more likely to feel healthier because they've got comprehensibility, manageability, and meaningfulness. And by comprehensibility, what he said, that is the extent to which your life, and by life, we kind of mean midwifery career in this perspective, or your midwifery job, the extent to which that is ordered, consistent, and understandable. So in respect to looking after asylum-seeking and refugee women in this project. The second element is manageability. So the extent to which life feels emotionally significant, worthy of investment and engagement. Oh, sorry, I got that the wrong way around. Manageability is around the extent to which you have sufficient resources to be able to navigate life as well. And then finally, meaningfulness, which is the extent to which life feels emotionally significant for you, worthy of investment and engagement in a way that doesn't deplete your well-being. Thank you, Ali. If we could have the next slide. So this study, for the purposes of transparency, did take place, the data collection for this study did take place during the COVID pandemic, just when we had all the lockdowns and everything. The study was delayed by a year, but anybody that's familiar with COVID in the UK will know that we had subsequent lockdowns after the first one. So after a year of delaying data collection, we decided that we would go ahead. And actually, I think it ended up being a strange key strength to the study, because what it did was really exacerbate and bring to light some of the inequalities that women were experiencing, and also how midwives navigate them as well. So the methods for the study, it was a qualitative study. We couldn't do focus groups because of the way that we weren't allowed to meet in public. But what we did was do semi-structured interviews as well, which gave us really deep data. In the wider study, I spoke to 20 women as well as the 14 midwives, but I'm just going to look at the data from the midwives today in this study, because again, we're going to talk about aspects that were invisible to women, but very, very apparent to midwives, and whether they could access help for women or not. The data was analysed using reflexive thematic analysis, and as I've already said, through a salutogenic lens. If we could go to the next slide, please, Ali. So I chose to look at data just from England, and that was because at the time, in 2020, 2021, there was some really quite big differences around perinatal mental health in the UK, and how that was kind of structured within Scotland, Wales, England. So for the purposes of a doctoral study and keeping it manageable, we did that just within England. I spoke to 14 midwives within 13 NHS trusts, and 11 of them held specialist roles. So a specialist role, for those who are not familiar, is a midwife who's undertaken some kind of extra training or preparation to develop an area of expertise in one particular community or population or area of midwifery. And the reason why that's interesting to this data is because there is no consistency in those roles in England. So some midwives were specialists in migrant mental health or migrant health, some were perinatal mental health specialists, some looked after women with complex social factors, which includes forced migrant women, but also includes younger teenage parents, people with domestic abuse, and substance misuse and addiction issues as well. So which makes it a very broad range of women. Some were specialists around areas of deprivation and poverty as well. So there was a real mix of those specialist roles. And another reason why the specialist roles are interesting is what became very clear in this data is that the healthcare provider had what they deemed to be specialist midwives in place, but they often held a role that wasn't direct clinical contact with women, or not as much as they would have done if they were just caseloading women. So they might have a helicopter view of the care that was going on and be trying to support other midwives, like almost like a puppeteer underneath, trying to support them and help them to help the community midwives to create navigable services for women. Out of those roles, only 8 of the midwives were only able to provide continuity of care. And I've been looking at this recently because I'm doing some postdoctoral research in a similar area at the moment. And the stats that are coming out are very similar. So in England and in the UK, continuity of care is actually reducing. It certainly hasn't got any better whatsoever. It'll be interesting to see how that is across the rest of the world. Next slide, please. So 3 themes came out of this part of the study, and they don't sound too positive at the moment, do they? I'm going to show you some quotes that make it sound not very positive. However, they were really good aspects that came out of each of these themes as well. So we're going to go through them in detail. So 3 themes that came out of things that were invisible to women, but significantly affected midwives' health and well-being was the difficulty that they had obtaining support for women who had clearly were struggling with their perinatal mental health, who didn't meet the remit for services one way or another. They also talked about the emotional labour of the role and the impact that that had on their health and well-being, and access to training and guidance to be able to do their role. And one of the things that became very, very clear in this, and this is where positionality as a midwife is quite difficult, isn't it? Because I am a practicing midwife myself. It was very, very clear speaking to the midwives that they chose their role. All of them chose their role working with forced migrant women. They gave their love, their time, their experience and their skills freely. But it didn't come without a cost to them and their emotional health and well-being themselves. Next slide, please, Ali. So there were definitely issues in obtaining support for women across all 14 midwives. One of the things that came out is, and there are very clear quotes to support this, is that midwives had a perception that asylum-seeking and refugee women were often deprioritised by healthcare services due to immigration-related complexity. So that might be consideration whether an asylum-seeking woman can access free perinatal mental health services. And depending on the area, sometimes mental health services, and depending on the immigration status that the woman has, perinatal mental health services might not be counted as an acute service and may be chargeable. So that could be an issue for women being able to access care. And this meant that midwives had to find somewhere else that could try and care for women so that they didn't go without any perinatal mental health care. They also found that when they were trying to broker services and get referrals into services, that sometimes women were declined because of their migration status, not legally because of their migration status, but because the service would say, oh, this sounds more like a migration issue than a perinatal mental health issue. And kind of what became clear is that midwives almost had to choose. Is it a migrant problem? Is it a perinatal mental health problem? But actually also the service could do that, so they could bounce around different services with no power to the midwife actually over what happens there, which meant that they needed to become a broker, whether that was brokering into our formal NHS services or whether that was brokering with voluntary agencies and third sector agencies to try and help women get the help that they needed. But that increased their physical workload and time that they use day to day, but also the emotional workload of that as well. Many of the midwives that I spoke to, in fact, at least 2/3 of the midwives that I spoke to, heavily relied on third sector agencies. And what we know from those third sector and charitable agencies is they do the very best that they can with the resources that they have, but their resources are tight. They're not commissioned in the same way. They're doing everything from small pots of funding, and they can't help everybody all the time as well, which left midwives kind of stuck in a bit of limbo with women as well. And that became particularly an issue when women presented with those perinatal mental health concerns, but more in that mild to slightly moderate range, where actually they didn't fit the remit for perinatal mental health services, but actually they were too much for the midwife to be able to manage her by herself in a way that gave the woman good care. And all of these factors affected the midwife's own health and well-being. Next slide, please. So we're going to look at a few different quotes and things like that, just to try and illustrate what was going on. So this particular midwife is a very experienced midwife working particularly just with asylum-seeking and refugee women. She works actually in a city that has a very well-developed service. This should be one of the better services in England, a large asylum-seeker and refugee population. And she just said, I work in a well-resourced setting, but I tried every single avenue. And I just thought, if anything happens to this woman, I'm going to feel responsible. Next slide, please. And I knew this is the midwife, but what that midwife was saying actually was illustrated by many other midwives as well. And it seemed like almost every midwife that I spoke to navigated those same issues. However, there were a very small number of midwives or pockets of good practice that were different in each trust, to be fair, apart from the bigger, really well-supported systems. But when midwives worked in these cohesive, supportive systems, it really improved their mental health, which then increased the amount of capacity and space that they had to invest in women as well. And midwives said they felt supported in systems when there was established protocols and pathways that were specifically relevant to asylum-seeking and refugee women. And I'm sure it's the same for everybody on here. Most of us work in countries and navigate systems and protocols and guidelines which are meant for the general population. They're meant as a catch-all for everybody. But they often then don't capture the needs of the more vulnerable people, or the resilience of some of those people as well, and the fact that they just need a slightly different service. When midwives worked in larger cities with established multidisciplinary or multi-agency pathways and working, that was much better. So we have some large cities in the UK with significant asylum seeker and refugee populations, where there is a critical mass, where they're then able to invest in services because they know they're going to have a larger footfall of people. So I'm going to give you an example. Liverpool in the UK has some fantastic services because they've got quite a large community of asylum seekers and refugee women. So they know that they can invest all these people to work in these services because they know they're going to have the footfall through them to make them economically viable at a commissioning level. But most cities and towns in the UK were not in the same situation. Therefore, they didn't have the economic argument for developing these services, which left the responsibility more on the midwife. Midwives who had full responsibility for managing that increased caseload of issues with a forced migrant woman were more likely to experience burnout, stress. Many of them had time off work with psychological distress themselves through feeling that they just couldn't effectively meet the woman's needs. But in systems like this, like in Liverpool, for example, that do, those midwives are more likely to thrive in those kinds of areas. And where midwives could provide continuity of care to women as well, that made a huge difference. And that's significant because a lot of the specialist midwives in this study actually couldn't provide continuity of care. They had more of a helicopter view and overview. But those who could see women appointment after appointment could then get to know the woman better, get to know her needs over time. And just like we know with all continuity of care, that made a huge difference to the midwife and the woman as well. Next slide, please. So this is an example from one midwife who worked in such a city just like that. Where she said, we've got a fabulous service, it's seamless, we've got a multidisciplinary clinic, you're there, there's someone from mental health, there's someone from housing, social workers, midwives, obstetricians, and actually the course itself is wider. Third sector organisations such as Freedom from Torture, the Red Cross, so people could get really specific trauma-informed support as well. But although this increases midwives' wellbeing and health, we need to accept that at this moment in time within the UK or within England, only a very small minority of midwives work in services like this. So I guess the challenge for us today is to think about how we could pull some of those little bits and make incremental changes in our own areas as well. If we can't do the whole thing, what can we do that makes an incremental change? Next slide, please. Theme 2 was around the emotional labour of the role. So as I've already alluded to before, midwives frequently experienced issues such as burnout and stress. Lots of midwives talked about having to take up to 3 months break from the role before they felt able to come back to it to replenish their own personal resources. Midwives felt an increased responsibility for the care of women with these complex social needs, not because of the women themselves. Sorry, I was going to take a drink. Not because of the women themselves, they enjoyed caring for the women, but because they found it very hard to access support and open doors for them. And they said that this left them at an increased risk in the UK or within England, an increased risk of something going wrong for women and for them feeling responsible for that. So perhaps a woman having a preterm labour or a stillbirth and worrying that actually when the notes were looked over, that they would see that this midwife with sole responsibility had missed something. And they just said, it feels like there's not as many people looking over the notes as there would be normal. There's not as many people contributing to her care. Therefore, if I get something wrong, this is on me. Really sadly, prejudice from other staff did come up within the data in a number of areas with some really quite distressing quotes from narratives that midwives had heard from other colleagues and midwives as well, feeling that doors were shut for forced migrant women because of their migration status. So quotes such as, the woman's got a roof over her head, what more does she want? She shouldn't have perinatal mental health issues, she's got a free house. And we have to hope that that is the very minority of midwives. And I do believe that is a small number of midwives. However, midwives caring for asylum-seeking and refugee women had that vicarious experience, that vicarious prejudice as well. And I think we do have to accept that actually, the UK is a hostile environment for many forced migrant women at the moment and forced migrant families as well. And that if we've got those attitudes within the normal population, then there is sadly going to be a small number of those midwives operating in our systems as well. And that midwives felt an increased responsibility for challenging that, but not always backed up when they were doing that, and needing to make sure and buffer that the women that they cared for weren't aware of that or experiencing it. They felt that the emotional load was invisible to their managers and their colleagues, that they didn't realise that caring for asylum-seeking and refugee women had these additional layers which increased their workload, but also the intensity of the emotional stuff that they were processing as well. They didn't work in a very trauma-informed service that recognised the impact on staff as well as on women as well. And midwives talked about being lone workers as well, which we've also already discussed. Next slide, please. So here's just a couple of quotes. So oh, we've lost the midwife's number at the bottom here. But one midwife said, people don't always know what we do, and certainly not our management. We're being exposed to bad stuff too, and that needs to be looked at. Oh, midwives 910, sorry, it's there. I can't see with my Zoom screen. And then another midwife, some midwives still struggle with asylum-seeking and refugee women having mental health issues, like, oh, they should be grateful they've got a room over their heads, which I don't know about you, but I just find it extremely saddening. Next slide, please. But, you know, having stated the negatives, there are midwives working in some systems or elements of systems which really, really help them. And the key one to this, to helping midwives' wellbeing in this respect, was external supervision. So somewhere, so for those that are not aware, supervision is in an external environment. You know, external supervision would be somebody who a midwife could speak to who is nothing to do with that workload, who is not an employer, who is not somebody who works at the healthcare organisation, somebody completely objective, who can be objective outside of that. And the reason that was important within this data is because they said that costs money, and very few healthcare providers were able to provide that. But when it did, that really helped midwives' wellbeing. They felt that they weren't taking it home, as you can see from the quote there. But actually, what's far more likely to happen, but felt less effective for midwives, is the fact that organisations often try to create their own informal supervisions to try and save money, but also to try and help the wellbeing of midwives as well, recognising that there is some vicarious trauma there. But when that was done by a line manager or another colleague within the team, it's subjective rather than objective. They've got different skin in the game. You know, they're part of the commissioning of the service, but also they know the restrictions of the service as well. And midwives felt that that was less valuable, and that actually they felt that their own practice was critiqued in that, so they were less likely to take things to informal supervision. So there's just a quote here on the bottom screen. So my manager said, "You're too nice. But then again, how would you feel if you were in that situation?" Next slide, please. And then the third and final theme was training and guidance. And what this showed was, if you look at UK clinical guidance, and this is still the same, so I'm doing a postdoctoral research project at the moment, and I've just been doing a deep dive into the clinical guidance, which has not changed since this first doctoral research. And actually, some of it hasn't changed since 2010. And some of our national guidance hasn't been updated in the UK because our NICE, who govern our clinical guidance, have said that there's not enough research out there, not enough high quality research out there to justify changing the current guidance that we have. Midwives were very, very aware of this when I spoke to them, and they're still very aware of this in the postdoctoral research at the moment. And what they were saying is that actually that manageability and the comprehensibility of their role was really lacking because there's no research, there's no guidance at a national level. So at a national level, it says that we should just screen everybody's perinatal mental health in our perinatal mental health guidance. In our care of women with social complexity guidelines, it says for forced migrant women, we should take great care to assess for FGM. We should make sure that they're eligible for care, and we should look after their psychological needs. But that's all it says. It doesn't say what those psychological needs might be or how we should do that, which means that local guidance, when it was developed, didn't have anything at a higher level to pull down from. And midwives in this study perceived that as a lack of investment in women and women's care, but also a lack of investment in themselves as well. Midwives, we're doers, aren't we? We always seek to overcome these issues. And what midwives did, specialist midwives, is they tried to write their own local guidance and their own standard operating procedures and guidelines to use and protocols to use within their own trust. But that took a long, long time to be able to do that. They sought training as well, but that training was often found in their own time, self-funded, and completed without any recognition from their employer. So it was something they did for their own nursing and midwifery council validation and to be able to give better care to women, but it wasn't something that was invested in by employers as well. And basically, midwives said that actually when this happens, this lack of investment is not just in women, but it's also in midwives as well. And they felt that actually having specialist roles in some respects was a bit of a tick box procedure, because actually if we were going to do that and take it seriously, then we'd put time and money in as well to changing that and improving care. Next slide, please. So we've looked at some heavy quotes there and some quite saddening quotes as well and powerful quotes, but how can we strengthen midwives' wellbeing? So just tying this up, let's go to and focus on what does work and what we can do. And what I want you to do from this is take away the fact that actually you might not be able to do all of these in your healthcare organisation, but are there some incremental things that you can do and that can be done? Because if we increase the care, improve the care for women, we're also going to improve the care for midwives as well. Next slide. So key recommendations that come from this study. I've tried to keep them as simple as possible, knowing that we're for a global audience, but remembering that actually this is based on a small study as well, so it's not a big RCT, but the findings from this small study is, we need to develop and implement some national evidence-based guidelines that looks at both perinatal mental health needs and asylum-seeking and refugee women. At the moment, they're divided into two different guidelines with not very much information in either of them when it comes to forced migrant women. I think it's upon us all in all our organisations that we need to really improve our cultural intelligence around caring for all minoritised women or global majority women. That we need, it's always easy to say that you just need more training, but we need our services to become more trauma informed, not just for women, but also for staff that navigate those services as well, in ways that respect and amplify and empower asylum seeking and refugee women's mental health needs as well as physical needs as well. They also need to be able to challenge that prejudice within that as well. We need to ensure that we have equitable access for women. So at the moment we've got multidisciplinary pathways, but we know from all our stats, and it's the same globally in most countries as well, most higher income countries such as Canada and Australia, the women that are accessing perinatal mental health services on the whole are white women that were born in that country. We know that it's not just as simple as addressing stigma and women's hesitation to accessing services. It's far too easy to blame them. But actually what we need to do is we need to make those services multidisciplinary so that we can all come at it from different perspectives as well, which will also reduce the burden on individual midwives as well, that we're going to share that load amongst ourselves. Next slide, please. Oh, time to finish up. Okay, sorry, I will talk quicker, we're nearly there. We need to introduce protected time for supervision for midwives, so and that external supervision where possible, but if not, somewhere external outside of the team, without a doubt. We need to include midwives and asylum-seeking women in the design of any of these services. And that's so easy to say that, but actually we really need to do it from the bottom up. And we need challenging workplace cultures. We should be able to challenge workplace cultures to really push against some of the prejudice that's out there. We need zero tolerance, but we need management support to be able to do that as well. We have areas that this is working well, and we need to mirror some of those. And then, Ali, I don't know if you want to just go to the next slide, which is the last slide. So my key message from today really is, if we strengthen the wellbeing of midwives, then actually that's going to filter on down or up to women. Strengthen the wellbeing of midwives is going to strengthen the mental health of asylum-seeking and refugee women that we care for as well. And that's my key message that I want to share today. So I'm going to stop speaking there, and let's have some discussion if we have time.
Thank you so much. You're getting some emojis there. So wonderful hearts. And then the question, Heba Farahalla asked, I have a question about reflexive, a thematic analysis. How did you use this approach during data analysis, please?
So I used all of the steps, which was around reading, but doing this with a supervisory team as well. So I used all the steps, so around familiarisation, initial coding, bringing together themes, working through that. But a big part of reflexive thematic analysis is also understanding your own positionality as well. So looking at the fact that I was viewing the data from someone who's a practicing midwife, so I've got investment in that there's no such thing as objectivity in qualitative research, but also my own post-colonial feminist stance, where actually I do hold a belief that our healthcare systems do other women who don't look like me. So being objective and transparent, being transparent about that as well within the data. That actually part of what I wanted to do was show where those gaps were. So reflexive thematic analysis doesn't pretend to be thoroughly objective. It really takes that philosophical stance and it brings it out transparently within the data analysis. So I did do that, and within my thesis there's lots of reflexivity around. Actually, other people might have looked at the data and seen something differently, but actually I was looking at it from a perspective of trying to find those inequalities and to amplify them.
I know we've only got a couple of minutes left, but this was a fantastic presentation. My it's not really a quick question. So obviously I live in a very diverse state. I live in Florida. Jacksonville, Florida is the most diverse city and largest city in the United States. So we do obviously have a lot of immigrant and refugee families to work with. And do you think, like, just quickly, the effect of AI, because one of our problems is obviously communication, because we may have somebody that we have to translate into another language and then actually translate into another language. So thinking about the impact of more effective AI communication tools for folks that don't speak this similar language to what we do. What's your thoughts on that moving forward for midwives' mental health?
So I've actually got really quite strong thoughts around it. I think AI can be really great. Within the UK, there is guidance that says we shouldn't be using it in emergency situations such as accident emergency or ED, and we shouldn't be using it in maternity situations. As a human and a midwife, I think one of the most fundamental things we do, human to human, is communicate. And I don't think we should be doing that through a machine unless it's a very basic question. And I really don't think we should be using it around mental health. Mental health is around relationship building. There's too much nuance and emotional loading in the vocabulary that we use that's so different language to language as well and culture to culture that I don't think we should be using AI to do it. I think we need to invest in humans at this moment in time. But that's my stance.
Fantastic. Yes, I've been encountered a lot of communication issues when we have people with with language that's not commonly spoken by anyone close to you. So that's and you're in emergent situations. So thank you so much, Amanda. If we could go to the next slide, and thanks. Let's all give Amanda an ovation for that wonderful presentation, and so prescient and time sensitive, really. And you're getting some claps here and some hearts and love